You're listening to Clinical Conversations. The journal PLOS ONE published an intriguing paper on midwifery in the U.S. last month. It showed that those states that best integrated midwives at all levels of their healthcare systems tended to have the best mother-infant outcomes. We're fortunate to have Dr. Saraswathi Vedam from the Faculty of Medicine at the University of British Columbia as our guest. Dr. Vedam is an associate professor in the Division of Midwifery there, and she's the first author of the study. Welcome to Clinical Conversations, Dr. Vedam.
Thank you.
Your paper reflects a large undertaking, examining the integration of midwifery into the healthcare systems of the 50 states. Can you tell us how you went about doing that?
It was a 5-year process. We had a fantastic multidisciplinary and multi-stakeholder team. The process started at a meeting of a multidisciplinary meeting around access to high-quality care across birth settings, which happened in 2011. And at that meeting, everybody who was in the room, the whole maternity care system, we had physicians, midwives, nurses, health administrators, policymakers, researchers, liability specialists, cost specialists, as well as consumers and consumer advocates, regulators. We had everybody there, and everybody agreed that there were huge disparities across the United States as far as families' ability to access the type of care that they wanted that was community-based and close to home, and that when the plan for their maternity care had to change. Say they were planning a birth center birth, but they developed some condition that was better cared for in the hospital. When they moved from one setting to another, sometimes the care wasn't coordinated well. So we decided in 2011 to start with just looking at what regulations, rules, and statutes said around midwives in the United States. We spent quite a bit of time gathering publicly available data. In every state, we found that the rules and regulations that guide midwifery practice and access to things like emergency medicines or ability to seamlessly transfer or even to practice to their full scope that they were prepared for changed dramatically depending on the state that you were in, and also were found in different parts of the law. So depending on how it started being regulated. So we started first with creating a very large database of all the rules and regulations, and then when we finished that process and came back to our team, our multi-stakeholder team, everybody felt frustrated and worried because it was so different, depending on where you lived in the country. And they said, well, how can we use this to inform practice? And the interesting thing is that the researchers in the room said, we've been waiting for a database like this, because when we look at CDC outcomes or try to study the differences in maternal and fetal health across the country, we know it's context dependent. We know that it depends on who's providing the care, who can access what style of care, how much communication there is, say, between rural and urban. But we've never had it's kind of like an environmental scan. We've never had the landscape described in such detail. So then we realized that we had to connect to make it make sense. Why do we care about regulation and oversight or access or even scope of practice for any particular type of practice? It only matters if it affects health, right? If it affects access to high quality care. And so we realized as we were going through the process that actually some states may have regulations that seem like it would facilitate access, but how the rules and regulations were interpreted on the ground in any particular community might change depending on who was there. For example, in one state, the law said that the midwives could access emergency medications, but the same state had laws requiring pharmacists to provide those medications only to a hospital setting. And these types of midwives, the certified professional midwives in that state at that time, did not have access to hospital privileges. So they could not access them. So the law said they could do it. Everybody had looked at the evidence around safety that you need to have access to this, and yet the interpretation of the law prohibited the woman's ability to get the best care. So then we stopped the press. We thought we were done, and then we had to go back and do a 50-state expert. We did a survey of regulators. We found 2 regulators in every state to help us understand how these laws were being interpreted and how they affected things, even like Medicaid payment or communication between types of providers. Once we did that, we harmonized the data and looked at every state. We always deferred to the most verifiable data. And then we decided to weight the different ways that it could play out. I was sitting there in the lens of a family, and if I looked at every single one of our 50 items and said, how will this regulation or rule or things like access to Medicaid affect a woman's access to the best quality care wherever she is? So we went through a weighting process where we decided that licensure was very important, but if you were in an illegal state for a certain type of midwife, or there wasn't that type of midwife in your setting, but somebody was able to provide care at the home that was skilled care, that was better, and they were able to access, say, consultation to hospital staff or specialist staff. Yeah. That was a better situation than if it was illegal. So in other words, it wasn't just zero yes and no. It was a gradation.
And from that evaluation of those 50 items, actually, I think you looked at more than 50. I think you looked at 105 or something like that. But
130 original items, yes, and there were some 196 ways you could score them. We decided on 50 key items that was this concept called integration. Everybody always talks about, we need integrated care. We need an integrated system, but we wanted to define what integration looked like, and then mattered to outcomes.
And then you put together a scoring system called MISS, and that stands for Midwife Integration Scoring System. Speaking of integration,
that's right. It helps you to understand how things like scope and site of practice, autonomy of practice, the ability to practice to your full ability and communicate with other providers connects. It scores, ranks your setting based on how well integrated care is. And then once we had that quantitative evidence-based way to look at integration, we could connect it to outcomes and see if that made a difference.
And so the perfect score of outcomes for mothers and babies would be 100. If you had a perfect score, if midwifery were fully integrated into a state system, but you looked across the states and you have scores that they appear in a table in your paper, and I thinking, I have the paper over here, but it's Washington State, I think, which is very close to
That's correct. So we looked across the country, and in an ideal system where care was integrated across wherever you were and across providers, an ideal system would have a top score of 100. And we were able to establish that integration matters, that in fact it connects to outcomes. So when we looked across the United States, the highest scoring state was Washington State, but it only had a 61 out of 100. So that should be pointed out, because there are other systems around the world that are more integrated than even Washington State. But Washington State was the top scoring state, and then there were other states that were down around, the lowest scoring states were around 17.
And your findings now in those states with regard to the most important elements in the equation, which is the health of the mothers and their babies. You used Centers for Disease Control data to verify that. And so what are some of the things that you found with that data?
Yes, so we looked at 9 key outcomes that are available in vital records. There's a lot of information that's captured in birth certificates, and there's a lot that's been said that birth certificate data because it depends on who fills it out and how accurate it is and how complete it is. So we wanted to use only those outcomes that were really verifiable, that were things that you couldn't make a mistake on. You had a cesarean or you didn't. Your baby was, because they actually put in the birth weight, the baby was low birth weight or not, the baby was born preterm or not. So we looked at cesarean rate, induction rate, preterm birth, low birth weight, breastfeeding at birth, breastfeeding at 6 months, and neonatal mortality. And physiologic birth, which was physiologic birth we meant was a vaginal birth without any kind of, so it's not just the opposite of C-section, but so without forceps or vacuum. So it's a physiologic birth as well. And so what we did was we went in to the CDC and there are reported, aggregate data. It doesn't tell the whole story because states can be large, but aggregate data about what the rates of those outcomes were in that particular state. And then we took the rates of outcomes and we separated them into quartiles. And we looked at the top fourth, the middle two quarters, and the bottom quarter of outcomes. That was a way for us to link the best and worst outcomes with the best and worst integration.
And you found, as I recall, the better the integration score, the better the outcome indicators were.
That's correct. So we were able to show that the greater the integration, the better the outcomes for all of those 9 outcomes. And we did a statistical technique called correlation coefficients. And the level of correlation coefficients, they were very, very strong correlations. So it wasn't just, maybe this is associated. They were very strong correlations. And that's how a lot of population data is looked at in public health. But some people might say, well, correlation is not causation. And that's absolutely correct. There are many other factors involved when you look at health of mothers and babies. There are many things that can have an effect. And one thing that struck us was that when we looked at the map, it was by looking at it visually that I had to ask myself, is this about red states and blue states? Is it about access to insurance? Is it about rural versus urban, or access to any maternity provider? So it was already a 5-year process. We were trying to be as careful and as transparent and as rigorous as possible. We weren't able to look at every possible confounder, but we did look at one very important confounder, and that was race.
And what did that show you?
Yeah, so that I suppose you have read that there has been a lot in the press recently about the differential experience of African American families, particularly around maternal and newborn health. Mm-hmm. And when we looked at the states, since I've lived in the United States for a long time, and I'm a person of color, I'm really aware of where the populations tend to live as far as communities of color. And just looking at the map where the worst outcomes were, I suspected that there was a confounder, and that was race, that in fact that many of the states that had the poorest health outcomes were also states where there was a large proportion of Black babies being born, and African American mothers reporting about their data. So I went back to the CDC and I asked the statisticians to give me the proportion of Black births that occurred by state, just to verify my visual impression. And in fact, we found that there was a lot of overlay over where there was the poorest integration. Were also in most of those states were also where there was a high level of Black births, and we also found that the outcomes were poorest in those places. So we then decided to do what's called a logistic regression analysis, which helps you to control for confounders. And when we controlled for the effects of race, and we did find that the correlations that we were finding with outcomes in those states, about 38% of them could be accounted for by race alone. But over and above race, we found that the level of integration was responsible for 10 to 12%, depending on the outcome you looked at. An additional improvement could be demonstrated just by the level of integration of midwives.
So, how does the U.S. compare with other first world countries in terms of its integration of midwifery into its systems?
The Lancet did a series on midwifery, and they also did a series on maternal health. The series on midwifery, I think, was in 2014, and then maternal health in 2016, so very recent. And what they did was evaluate the state of maternal newborn health globally. And this is because we know with the Millennium Development Goals, they didn't reach those targets. Those are the two targets they didn't reach. Mm-hmm. So now when we're in an era of what's called the Sustainable Development Goals, looking at both the Global South and the North or high-resource countries, the Lancet authors, which were multidisciplinary teams, a very, very sophisticated analysis of what needs to be done, both series recognize that if in settings where midwifery was well integrated, outcomes were better. And so this has been sort of shown globally, and it's also been shown that there are differences among high-resource countries as well as low-resource countries. So in settings in high-resource, to answer your question, there are many countries that have greater integration than we do. We haven't actually measured it the way we've done it now in the U.S., but just knowing the items that we looked at that make up the MIS score, we know how those items would be answered in Norway or Sweden or Canada even, or New Zealand. All of those countries have better integrated systems and have better outcomes.
So what would you like clinicians to take away from your study?
Yeah, so that's a great question. There are many. I think this is a moment to really sit back and evaluate our local situations. One of the exceptions that we found was New York State. So New York State has a high proportion of African American families who live there, and also a high integration. And unlike the other states that had very high neonatal mortality, or low birth weight, or preterm birth, New York State had one of the lowest. It was in the lowest quartile. Yeah. So, let's look at it. Let's look at Washington State. Let's look at New York for the care of communities of color. Let's look at jurisdictions where things are working, instead of and let's see what are they doing in their healthcare system. What can you look at around in your own hospital, your own setting, to see who's practicing there? Where are families? We know that the families choosing birth in homes and birth centers there's a greater increase in interest in those options. Still, it's less than 2% across the United States. It's really not, this is not a home birth story. This is about maternity care generally, and with most of which happens in hospitals. So look at your hospital. Look at who's providing. If your practice includes maternity care and there are midwives or no midwives in your setting, maybe ask the questions of your administrators or your health systems people or your professional associations about how you can work with them to respond to these findings and say, how can we increase access to covered care for everybody? How can we all work together? There are not enough of us. There are many mothers and babies out there. We know there's a problem. How can we facilitate access for families together and communicate well with each other and collaborate to provide care?
So that would be your advice both to clinicians as well as to policymakers and medical societies, I would guess.
Yes, I think that for policymakers, it's a different task, and that is to really examine what the differences in the rules and regulations are in your jurisdiction that might be providing barriers to that accessing that kind of care across, or barriers to communication. There's probably a work that needs to be done around helping people feel comfortable that their liability won't be increased if they collaborate with other providers. We know that comfort's already there. Family physicians who work in rural settings routinely have to make decisions about moving somebody they're caring for to a tertiary or a higher level of care. And now we know that how well that communication goes, and it's affected, and whether or not the chart's available, whether or not the receiving provider understands what needs to be done. There are no delays. that improves outcomes. So this is really the same story that we're talking about, is that when we work with other providers, and rather than trying to say, in the old system, there was a kind of a hierarchical system in all healthcare. Now everybody's talking about team-based care. Uh-huh. And that's, in fact, what families want, too. They want to be sure that nothing is missed. Things don't fall through the cracks. So, for example, if there are nurse midwives in your hospital and they are able to provide follow-up or the time required to manage a complex care in collaboration with you, maybe that's the best care, a collaborative model where, there's both expertise for, say, something like, we know newborn health. We know that newborns do better when they are successful breastfeeding, and we know that midwives often will provide follow-up care, postpartum care, to support, say, something like breastfeeding. And while they're there, they're going to notice things like high blood pressure or problems with bleeding and things like that. So it's interesting to see when you have people involved in your care, even if that's not what, they're going to eventually refer you to another provider, it's the vigilance that makes a difference, right? So we know that from community health nursing also.
I wanted to make sure to point our listeners to your website, which is birthplacelab, all one word, .org, because on that site you've got some interactive maps and other resources that interested people, I'm sure, would appreciate seeing. I will put those links, because when you're listening to something you can't write it down, but I will put those links in the podcast, so people who go to podcasts.jwatch.org will find them there. And
that's great. They can also look at their own state and see state report cards. Right. They can see what's happening in their own jurisdiction.
Right, and it's not a simple story; it's rather complex, as you pointed out. And it's International Women's Day, isn't it?
It is, thank you. Yes.
And as I was interviewing you, I thought, wait a minute, this is International Women's Day. The New York Times tried to make up for its past failures in writing obituaries about famous women. I guess they're going to do it retrospectively. Well, at any rate, happy International Women's Day.
As a mother of 4 daughters, I will say thank you.
Okay. I want to thank you for spending time with us today.
Thanks.
That was our 218th edition. All earlier conversations may be found at podcasts.jwatch.org. We come to you from NEJM Journal Watch. Kristen Kelly is the executive producer here for the NEJM Group. I'm Joe Elia. Thank you for listening.